So in this session we're going to talk about fluids. Now fluids are really important because in the generic approach session we use fluids as part of our 5 in terms of our management arsenal. And really it's clinical bread and butter. You're going to be doing this all the time, but that doesn't make it easy, so it's worth talking about in this session. We can all recall a patient that's been inadvertently overloaded by the wrong administration of IV fluids. And I can remember as a newly qualified junior doctor not knowing what fluid to give or not knowing what rate to administer fluids. But something else makes fluids hard. It's that idea that as a junior doctor you're going to lose count of the number of times that you prescribe an 8-hourly or a 12-hourly bag of fluids. But how often are you going to be the one that sees the effect of those bags 8-hourly or 12-hourly down the line? In fact, it's going to be your colleague who, having never met that patient before, is going to be bleeped and asked by a nurse to come and prescribe another bag. How do you come to a determination about what a patient's fluid balance is like? How do you safely prescribe fluids and interpret urea and electrolyte results? How do you do this for patients that are nilled by mouth, have a high output stoma, or they have comorbidities like congestive cardiac failure or chronic kidney disease? And how can we accurately monitor and reassess our patients in terms of their fluid balance? As always, let's go through a systematic approach to this clinical problem and decide how we safely prescribe or withhold IV fluids. So fluid balance is a homeostatic idea that the fluid that we lose is equal to the fluid that we gain through food and drink, or to a lesser extent, the water that is a byproduct of our aerobic respiration. If a patient is physiologically healthy and their fluid gains are equal to their losses, then we can say that they've achieved their homeostasis and we can label that patient as being euvolemic. As doctors, we're far more interested in the patient whose balance is upset and they're at either end of that spectrum, and we could think about the hypovolemic patient or the hypervolemic patient, because either of these situations can have detrimental clinical consequences for your patient. Before going further, let's consider a few basic facts. The average 70-kilo man is our textbook man. He's 60% water, so that's 42 litres. So 2/3 of his 42 litres are going to be in the cells, and that's the intracellular fluid. And the remaining third is going to be outside of cells, and we call that the extracellular fluid. And the extracellular fluid is further subdivided into the fluid that is intravascular, and that's 1/4, and the fluid that's around the vasculature and around the cells, which we call interstitial fluid, and that's the remaining 3/4 of the extracellular fluid is interstitial fluid. When we administer fluids, we're administering them into the smallest body compartment. We're pushing them straight into the intravascular compartment. And we need to be aware about how that fluid distributes itself across the entire body water. It's no good giving fluid for a patient with low blood pressure in an attempt to raise their blood pressure if the fluid that you give into the vein is going to go straight out into the interstitial or intracellular compartments. So what determines the fluid distribution? It's the fluid's makeup. So the electrolyte composition of the intracellular and extracellular fluid will vary. Intracellularly, the main cation is potassium, and extracellularly, the main cation is sodium. And the makeup of the different types of intravenous fluid will depend on whether that fluid stays in the vasculature, moves out into the interstitial fluid, or moves into the cells. There are 2 types of intravenous fluid. There are the crystalloids and the colloids. So crystalloids is a water and electrolyte solution. So the electrolytes are really small molecules that are able to pass through a semi-permeable membrane. So when we administer these, they will distribute throughout the entire extracellular space, and the charge on the particles will stop it going intracellularly. In other words, if we put a crystalloid into my vein, some of it will stay intravascularly and some of it will move to the interstitial space. Colloids are also fluids that contain water and electrolytes, but they also contain a colloid, and a colloid is a large polymer molecule. And this molecule doesn't pass through semi-permeable membranes, it sits intravascularly and it exerts an osmotic pull, and so in theory more water will stay intravascularly than leak into the interstitial fluid. However, at the present time I need to stress that there is no convincing evidence that either colloids or crystalloids are superior at increasing intravascular volume. Crystalloids are cheaper and they tend to be used more often. And it's also worth pointing out that colloids are associated with a risk of anaphylaxis and also associated with coagulopathy. So I'm just going to concentrate on crystalloids, and I'm going to talk about 3 different types of commonly used crystalloid. 0.9% sodium chloride, compound sodium lactate, which can also be called Hartmann's solution, and 5% dextrose. So let's talk first about compound sodium lactate and 0.9% sodium chloride. And on the slide here, I've given you the electrolyte makeup of these solutions. Both have a sodium concentration that, although different, is similar to that of the extracellular fluid. And this limits its distribution to the extracellular compartment. So if you were to administer 1 litre of either of these 2 fluids, it would immediately distribute throughout the entire extracellular fluid. With only about 250 mils, that's a quarter, staying within the intravascular space, and the rest redistribution to the interstitial space. So the general rule is that a quarter of the fluid will stay in the intravascular compartment. So for 100 mils of blood loss, you're going to need to give 400 mils of 0.9% sodium chloride. One thing I want to point out now is that 0.9% sodium chloride is also called normal saline. But I want to say here now that there's nothing normal about normal saline. When you consider that there's 154 millimoles per litre of sodium and the same again of chloride, this number is well above the physiological parameters inside the body. So if you give prolonged administration of these fluids, you're going to push up the levels of these ions and in turn cause hypernatremia and hypochloremic metabolic acidosis. I also want to point out one important difference between compound sodium lactate and normal saline, and that's that Hartmann's solution, compound sodium lactate, has a small amount of potassium at around 5 millimoles per litre. So you shouldn't use this if hyperkalemia is a problem. Lastly, I come to 5% dextrose, which is a sugar-water solution, and I don't use this very often because it's isotonic in the bag, but because the sugar component is very quickly metabolized by the liver when you administer it, it's actually the same as giving pure water to your patient. So really, it's isotonic in the bag, but in the body it becomes very quickly hypotonic. And it's going to distribute throughout all of the body compartments, with only about a 1/12 of your 5% dextrose staying intravascularly. So for that reason, it's a really rubbish resuscitation fluid. But you might see it being given slowly in a patient who is dehydrated or hypernatremic and hyperosmolar. It provides a small amount of calories but no electrolytes whatsoever, so it's a really common cause of iatrogenic hyponatremia. So we're going to move to the clinical aspects of this topic now, and we're going to ask a question. What's the difference between hypovolemia and dehydration? It sounds simple, but it can be confusing because you'll see clinicians using these 2 terms together, and they can occur together. But let me give you a really simple example to make you see how ridiculous this is. If you imagine a young patient that's in a motorcycle accident and he's knocked off of his bike and he's bleeding, you wouldn't describe that patient as being dehydrated, but you would describe them as being hypovolemic. When we talk about hypovolemia, we're talking about the loss of sodium and water from the extracellular space. This occurs with hemorrhage, diarrhea and vomiting, and diuresis. The hallmark of hypovolemia is hemodynamic instability, where a patient is dropping their blood pressure and their pulse is climbing. Catastrophic hemorrhage is an example of hypovolemic shock. Blood is lost from the intravascular space and the patient becomes hemodynamically unstable. When we administer fluids in this situation, we're doing it to try and increase the blood pressure, to try and maintain a tissue perfusion pressure and maintain oxygen delivery to the tissues. In this particular example, catastrophic hemorrhage, the ideal fluid to administer is blood itself. Dehydration is a different clinical situation. Dehydration is a loss of water, but not sodium. The loss of intracellular water will lead to cellular desiccation. If this is left to continue, the patient will become hypovolemic, but they're not necessarily hypovolemic at the outset. So in the dehydrated patient, which might be an older patient, that you see on the wall, the loss of water will lead to high concentrations of solutes in their blood. And the hallmark, therefore, of dehydration is hypernatremia and a hypertonic plasma. The dehydrated patient needs oral rehydration, or they need slow IV fluids to try and increase their body water. This is different from the hypovolemic patient. The hypovolemic patient is hemodynamically unstable, so they need fluid boluses given in a way to resuscitate them. How are you going to diagnose hypovolemia then? Because that's the one we want to talk about today. As with all our videos, we're going to advocate a systematic approach to clinical assessment that moves through a process of history, examination, investigations. So we're going to start with history and examination, and I want you to pause the video at the moment and think about the questions you're going to ask for in the history, and then think about the signs that you're going to look for in the examination to ascertain what someone's fluid balance is. Are they currently euvolemic, or are they hypovolemic or hypervolemic? So hopefully you've got some of these. In the history, you're going to ask your patient, are you thirsty? How much have you had to drink today? Can you quantify it for me? How many jugs? You're going to ask them when the last time they passed urine was. How many times have they gone today? What colour is the urine? Is it dark and concentrated like apricot jam, or is it clear enough to drink? Ask them if they're vomiting, and ask them how many times they've vomited and how many bowls have they filled up. If they've got diarrhoea, ask them the consistency of the diarrhoea and how many times they've opened their bowels. Ask them if they're feeling hot and sweaty. And then all of those symptoms are symptoms of someone that's hypovolemic. So now ask them for the absence of features that would suggest otherwise. Ask them for the absence of features that would suggest hypervolemia. So ask them, do you get short of breath when you lay flat? You're asking about orthopnea. Ask them about how many pillows they sleep with at night. Ask them about paroxysmal nocturnal dyspnea. Do you ever wake up breathless in the night and need to get up out of bed because you're so breathless? Ask them about lower limb swelling. Move on to the examination now, and we're trying to get a sense of where they are in the fluid balance spectrum. So start at the hands. Feel them. Are they warm and well perfused? What's the pulse like? Does it have a good volume? Take a capillary refill, holding the hand at the heart level of the heart, compressing the digit for 5 seconds and then seeing what the capillary refill time is like. Is it prolonged in a hypovolemic patient, or is it okay? Take the blood pressure. Okay? The supine blood pressure might be low in a patient that's hypovolemic, and it might be high in a patient that's hypervolemic. But go further than that and do a postural blood pressure. Take that blood pressure supine, then standing at 1 minute and 3 minutes, and ask the patient if they've got symptoms like postural dizziness. Can you see their JVP in their neck? Do their eyes look bright? Is their tongue wet, or is it furrowed and dry? Do they have a dry axilla? This is especially useful in children that can't talk to you. And confirm the absence of signs that would suggest hypervolemia. So look for that raised JVP that's wiggling the earlobe. Listen for bibasal lung crepitations that would suggest pulmonary edema. And look for lower limb pitting edema, or in someone that's been in hospital a long time, feel for sacral edema. Whilst you're at the bedside, to complete your clinical assessment, it's really important to look through the bedside folder. Look at the patient's fluid balance chart. This should be filled in correctly because it's so useful to you. The nurse would have charted all of the inputs and the outputs, including urine, vomitus and drains. And from this, you can calculate a net fluid balance for the last 24 hours. The chart, if it's filled out incorrectly, gets increasingly more useful as the patient goes through their hospital admission. You should be particularly interested in how much urine the patient's passing. And if you're worried that a patient might be hypovolemic, you need to consider a urinary catheter with an hourly urometer, and you need to ask the nurse to record hourly urine outputs. The minimum urine is 0.5 mils per kilo per hour, and you should be aiming for well above that. You also need to look at the stool chart, and you need to see what's being passed and the consistency of what's being passed. You can lose a considerable amount through the stool chart, especially if the patient's got a stoma that's high up in the GI tract, like an ileostomy. Something that's worth mentioning, although we're talking more about the hypovolemic patient, In the hypervolemic patient, something that's really useful is a daily weights chart. Any fluctuation in the patient's weight over a 24-hour period is going to be because of fluid. So you can see that going in an upwards trend in someone that's getting too much fluid, or you could see it coming in a downward trend in someone that's diuresing, having previously been hypervolemic. Lastly, it's really important to leaf through the patient's drug chart. You're looking for diuretics and laxatives that could be contributed to fluid loss, and you also want to see how much IV fluid they've had already. If you think the patient's hypovolemic, there is certain drugs that you need to stop as well to protect their kidneys. So diuretics should be stopped because they're making it worse, and non-steroidal drugs that might be used for pain relief and ACE inhibitor medications that are used for blood pressure need to be stopped because they're going to affect renal water regulation and they're going to worsen any kidney injury in a hypovolemic patient. Let's just recap what we've talked about, because I want you to understand that each point in the history and each point in the examination is a piece of a jigsaw puzzle that makes up a big clinical picture. You can't determine someone's fluid balance just from the capillary refill or just from the JVP. You need to look at each jigsaw puzzle with its different degree of sensitivity and specificity, and then make up a clinical picture. I want to make the point to you that you don't just look for things that are there. You don't just look for positive signs, but you also look for the absence of signs. So in order to diagnose someone as being hypovolemic, you want to figure out all of the symptoms and signs that would suggest hypovolemia. But you also need to look for the absence of signs that would suggest that they are actually fluid overloaded. Having clinically assessed the patient, there are some blood tests that you can use that are particularly helpful. You don't need to take blood from every patient that you're asked to prescribe fluid for, but certainly it's best practice that the patient would have had a baseline set of urea and electrolytes before starting fluids. And that urea and electrolytes test should be repeated with every 24 hours that the patient remains on IV fluids, because it's really important that we're monitoring the concentration of electrolytes in their blood. When you're called to see a patient and the nurse shoves a drug chart in front of you and says, "Can you prescribe another bag?" not only do you need to go and clinically assess the patient, but you need to look at their last set of U's and E's to make an informed decision about what fluid you're going to prescribe. Urea and electrolytes is not just about looking at the levels of electrolytes that are low and giving those electrolytes back. There's a lot that can be gleaned from the urea and electrolyte results. We've already discussed that the hallmark of dehydration is hyponatremia. But remember, dehydration is water loss, so everything in the blood will be at a high concentration. And you can confirm your thinking that this patient's dehydrated by looking for hypernatremia, but also looking for an increased hemoglobin concentration, or packed cell volume, or hematocrit. In a dehydrated patient, the solute concentration will go up, leading to an increase in the plasma osmolality. So you could calculate the plasma osmolality if you wanted, 2 times sodium plus potassium, plus urea, plus glucose. If that patient has a high plasma osmolality, they need more water. We're going to move on to talk about hypovolemia now, and what tests might help you confirm the presence of hypovolemia. You might remember that creatinine is used to estimate a GFR, and also we look for a rise in creatinine above a patient's baseline to confirm the presence of an acute kidney injury. But I want to introduce you to the urea and creatinine ratio, because this is a really useful test for confirming that a patient might have hypovolemia. I'm going to give you a bit of background. It's going to take a few minutes, but it's important. The reason why creatinine is used to estimate a GFR is that it's freely filtered by the glomerulus. It isn't reabsorbed as it passes along the tubule, and then everything that's filtered is excreted. It's not entirely perfect for the job, because a small fraction of creatinine will be secreted by the tubules itself, and it will lead to an overestimation of GFR. But we're willing to forgive creatinine that. The important bit is that it isn't reabsorbed by the tubules. So in hypovolemia, all of the creatinine that's filtered by the glomerulus will be excreted. The reason why creatinine concentration will go up in the blood in hypovolemia is because there's decreased renal perfusion and the creatinine stops being filtered. But everything that is filtered will be excreted. Urea is also freely filtered, but it's reabsorbed by the kidney. And in fact, this is physiologically important. Urea is osmotically active, and the kidney needs to reabsorb urea into the renal medulla in order to reabsorb water. So in hypovolemia, the kidney will increase the reabsorption of urea in order to increase the reabsorption of water. So in hypovolemia, the concentration of urea will go up, but because it's being actively reabsorbed, it's not just through a lack of filtration, the urea will go up much more than the creatinine. And in hypovolemia, you might see an isolated rise in urea, and that would point to the patient being a little bit dry. Or you might see both the creatinine and urea go up, but in hypovolemia, the urea will go up many more times than its counterpart, creatinine. Just one disclaimer that I want to point out now is that if you do see a patient with an isolated rise in urea, this is also a sign of a possible upper GI bleed. Now that patient might be hypovolemic as well, but we're going to talk about urea and its use in GI bleeding in another session. One last test before moving on, I want to mention the venous blood gas, because the venous blood gas can be obtained quickly with near-patient testing. And I'm specifically thinking about a lactate, because we're talking about a hypovolemic patient that might be in hypovolemic shock. This is where they're not adequately perfusing their tissues, so these tissues are going to switch to anaerobic respiration, and they're going to produce lactate. A high lactate will confirm hypovolemia, if that's what you're thinking. But also, good fluid resuscitation is going to decrease lactate production and also promote lactate clearance in the kidney. So seeing this number come down as you're ongoing with your fluid resuscitation is a reassuring sign that you're doing the right thing in a sick patient. Now we feel a little bit more confident about assessing a patient's fluid balance. Let's talk a little bit about fluid prescribing, because this is important and this is something that you're going to be doing every day in the job. We've already alluded to this, and you should know that there are 3 situations in which you put pen to paper and prescribe IV fluids. Number 1, the maintenance of ongoing losses. Number 2, resuscitation. And number 3, replacement of abnormal losses. Let's talk about maintenance fluid. As human beings, we are simply bags of meat that are constantly and continuously dehydrating. There's water in our stool, in our urine and on our breath, and we lose water for our skin with sweat, which increases in increasing ambient temperature. As such, we've got a minimum water requirement. So the purpose of maintenance fluid is to replace these ongoing losses. They're measurable losses, like urine output, and insensible losses that we cannot measure, such as the fluid on our breath and through sweating. If a patient's euvolemic and well hydrated, but you make them nil by mouth, you now need to give them the fluid necessary to keep them at that steady state fluid balance. So the normal daily fluid requirement to maintain a healthy 70 kilo textbook man is between 2 and 3 litres, because the individual is going to lose about a litre and a half in their urine and about half a litre in insensible losses, give or take some. But we're not all 70 kilo men, and so let's go by the NICE guidance, which recommends 25 to 30 mils per kilo per day of water. In obese patients, you're going to need to use their ideal body weight to avoid overloading them. And in patients with congestive cardiac failure or chronic kidney disease or the elderly in general, you should use a lower target, and NICE suggests 20 to 25 mils per kilo per day. We also need to consider electrolyte requirements, not just water. And this is really easy. NICE recommend 1 millimole per kilo per day of sodium, potassium and chloride. And they also recommend 50 to 100 grams of glucose daily to limit starvation ketosis. We've talked about maintenance. Now let's talk about resuscitation. If you're with a patient and you confirm hypovolemia and they are hemodynamically unstable, you've ruled out any signs that suggest they might be hypervolemic instead. You decide that they need resuscitation. The safest way to do this is through a fluid challenge. This is where you administer a small amount of fluid over a quick period of time. So I would suggest 500 mils of fluid is never going to cause a problem. So if you give 500 mils of fluid over about 15 minutes, you can then look for a response to that fluid in terms of the patient's vital signs. Their heart rate might come down, their blood pressure might go up a little bit, and they might start producing a bit more urine over the next hour. You might need to repeat this as well if they've not completely resolved their vital signs. So a fluid challenge is where you give a repeated bolus, constantly monitoring and making sure that you're not giving too much. In my opinion, this is the sort of patient that as a junior doctor you stay with. You stay with them, you closely monitor them, and you even give the fluids yourself. Lastly, let's talk about replacement. Replacement of abnormal losses. The patient isn't clinically hypovolemic. They're not hemodynamically unstable, but they are losing fluid and they're losing electrolytes due to some pathology or something that we've done to them. So this includes the fluid that's collected from surgical drains, stomas, nasogastric tube aspirates, vomit and fistulae. The fluid balance chart is vitally important for you to get this right, and it needs to be accurately filled out. The source of the fluid loss will determine the type of electrolyte lost. So there's considerable variation in the electrolytes that are lost from different parts of the gastrointestinal tract. Loss from the upper tract tends to be high in sodium and acid, and losses from the bottom end tend to be high in sodium and bicarb. It's also important to point out that all GI secretions tend to have quite a high degree of potassium, and patients that are continuously vomiting or have diarrhea will drop their potassium, and it's important that you replace this and closely monitor their serum potassium. So we talked about maintenance, resuscitation and replacement, and we need to put this together. If your patient is hypovolemic, you're going to give them a fluid challenge in order to resuscitate them, and you're going to monitor for a response to that challenge. If your patient has no features of hypovolemia, and you want to avoid this, either preoperatively or postoperatively, then you need to think carefully and calculate their fluid and electrolyte requirements for the next 24 hours. And to do this, you need to calculate their maintenance fluid requirements, and you also need to look over the fluid balance chart and calculate how much you need to give back for what they've lost over the preceding 24 hours. You'll be pleased to know that that's the end of this session. And we've talked through the importance of fluid balance, how to assess your patient's fluid balance status. And the way we did that was we said we looked for signs of hypovolemia and we looked for signs of hypervolemia and saw what the big clinical picture said. And we've also talked through the process of prescribing fluid. And I just want to make a few points. Number one, always perform a clinical assessment to decide on the current fluid balance before you prescribe. Ask yourself, why are we giving fluid? Is it for resuscitation, maintenance, or replacement? Number two, decide on the type of fluid that you want to give by looking at the latest use needs results and thinking about what the intended purpose of that bag of fluids is for. Review the fluid balance chart for any replacement losses, because that will determine the amount of electrolytes that you need to give back and what salt. Lastly, consider the patient's size. Are they the textbook 70 kilo man, or are they the different ends of that spectrum? And consider whether they've got any comorbidities such as congestive cardiac failure or chronic kidney disease that might mean that they're predisposed to fluid retention, because they're the patients that you need to be a bit more careful with. We hope that this has been a useful resource that pulls together some more information from different parts of this site. But before you go, I want to point you towards our fluid prescribing article in the perioperative care section of this site, because it's got a lot more detailed information on this topic. Join us again sometime soon and we'll explore how we approach a different clinical scenario.